Warm good afternoon. At the outset, I thank the team Chennai for this opportunity. For the next 30 minutes, we are going to discuss about how to approach a patient with a thyroid nodule. So with us, we have an eminent panelist, which include endocrinologist and surgeon. Because of want of time, I'm not going to introduce them. I may call upon Dr. Krishna, Dr. Subramaniam, Dr. Usha, and Dr. Dalapati. So we know that thyroid nodules are common in clinical practice, and most of them are benign. And epidemiological studies have shown that the prevalence of palpable thyroid nodule to be approximately 5% in women and 1% in men living in iodine-sufficient parts of the world. Even though the ultrasound studies have shown that the prevalence as high as 25 to 50%, but the palpable thyroid is around 5%. The clinical importance of thyroid nodule rests with the need to exclude thyroid cancer, which occurs in around 7 to 15% of cases, depending upon the age, sex, radiation exposure, and family history. So with this introduction, I'll move on to my first case scenario. This is a real case. This is a 32-year-old patient present with history of swelling of the neck for the past 3 years. And she noticed a gradual increase in size of the swelling, but she's not bothered because it doesn't cause much problem to this lady. But later, she noticed difficulty in swallowing for solid foods and also difficulty in breathing on lying down. That's prompted her to meet an endocrinologist. There is no history of any hoarseness of voice, no history in a family suggestive of thyroid malignancy. There is no history of radiation in the past, and she doesn't have any history suggestive of hypo or hyperthyroid symptoms. So this is the patient. There's an obvious thyroid swelling in the right side, and on examination, the thyroid nodule is of 3 into 3 centimeter, was palpable in the right side of the gland, thyroid gland. It is firm in consistency, and it moves with deglutition with lower borders palpable. There is a slight tracheal shift to the left side with cervical lymph nodes are not palpable. So with this case scenario, an young lady with thyroid swelling for the past 3 years duration. So how to approach this patient? So I asked Subramaniam, any patient who come with a thyroid swelling, what are the indicators of malignancy? What are the red flag for malignancy in this type of patient?
I think you've given a very nice history and physical examination. I think that forms the crux in the beginning. I think a lot of times we somehow bypass this first step. We sort of go quickly into imaging and more sophisticated testing. It's important to, again, go back to the history, how long they've had it. Have they noticed a significant change in size? Have they noticed any symptoms? And you pointed out certain important symptoms that might suggest that there may be some amount of compression to nearby anatomical areas. So that becomes an important clue. All these add to your pre-test probability of whether this is going to be a benign or a malignant nodule. Ultimately, I think that is the goal or the evaluation of any thyroid nodule, is to see if it's going to be a benign nodule or a malignant nodule. So with the given scenario at this point of time, I think the next important step would be an ultrasound neck. An ultrasound neck forms most important step in evaluating thyroid nodules, and preferably done by somebody who does neck ultrasound at a very regular basis and is trained in doing thyroid neck ultrasounds at a systematic way. So that would be my first next step.
Okay. So TSH, an initial TSH will give a clue regarding the functional status of the thyroid. We know that it is a fairly large swelling. So regarding the functional status, the TSH may help. How TSH helps in...
Can you just go back to the values? It'll be easy.
I'm not given any values.
Okay.
I'm just given...
So two things, just to reiterate what Subramaniam Kannan said. Many years ago, Ernest Massaberry looked at the pretest value of physical exam in predicting this thing. And he looked at that there are some features, if present, if more than 2 of them are present, the positive predictive value for malignancy from a clinical exam was so high that even an FNAC is negative, that means you should exclude it. So that, just to reiterate it. Second is, there are 2 interesting things about the TSH. One is, if the TSH is suppressed, that is indicative that the nodule or the surrounding thyroid may be hyperfunctioning. This is one. Also remember that you may have one palpable nodule, the patient may have multiple nodules. This is the second part. The third is that, so when the TSH is suppressed, then it leads you to another pathway looking at hyperfunction. If the nodule is, so there, I still do a 24-hour radioiodine uptake and a scan. Many people are comfortable with the technetium 99M. I come from a very old school which still talks about iodine as more important. But in most general practices, technetium is available. It's a good test. The caveat, of course, is a discordant test where problems have to be looked at. So this is coming with a low or a suppressed TSH where you want to get a nuclear imaging of the thyroid. You will have three patterns. One, the nodule takes up this thing and the surrounding is suppressed. This is a autonomously functioning thyroid nodule, which in the olden days we used to call Getz disease. Sometimes you can have patchy uptake in multiple nodules that indicating autonomy of various regions of the thyroid. This is your classic toxic multinodular goiter. The third pattern that you will see is that the nodule itself is not taking any isotope. The surrounding thyroid is lighting up a Christmas tree. This is a nodule, a cold nodule in someone with Graves' disease. The risk of malignancy is slightly elevated. The chance of multicentricity is also high. The corollary is also important. That is, if your TSH, as the TSH increases, the risk of malignancy in the gland also increases. So someone has a TSH that is 7 or 8, for the same person, let's say two people who are identical, a person with a TSH of 8, as opposed to a person with a TSH of 2, the person with the TSH of 8 has a higher risk of malignancy.
I think it's very nice. One thing is, first step we have to do is to do a TSH to see the functional status. And then if the TSH is normal or elevated, then probably we have to move on to the next step of ultrasound. But if the TSH is suppressed, probably we have to do a thyroid uptake scan. Sometimes we may find these type of findings. This is not from the patient. This type of findings like a toxic thyroid nodule, which overfunctioning. The simple treatment will be to do an I-131 ablation for this patient. So we know that an ultrasound plays an important role in risk stratification of thyroid nodules. So what are the role of thyroid ultrasound in a thyroid nodule? Usha, please.
As you've mentioned, and as the other panelists have already mentioned, in a thyroid nodule which is associated with either a normal or an elevated TSH, ultrasound can be extremely useful in deciding which nodule needs an FNAC. There are certain typical factors that are described in terms of ultrasound appearance of thyroid nodules, and some of these include whether they're taller than wide, what the margin looks like, whether you can pick up any calcification, whether there's any surrounding invasion, what the lymph nodes are like, and depending on these, you're given what is called a ThyREDS classification, which is the thyroid imaging classification. And nodules that have a low clinical index of suspicion on an ultrasound can be followed up either through sequential scanning, or if they have a very low clinical suspicion, or if they're purely cystic, you can actually reassure the patient. Nodules that have that are slightly larger, maybe 1 to 1.5 centimeters, that have a moderate to higher index of suspicion on an ultrasound will need further action in terms of an FNAC. And nodules that look clearly suspicious will need an FNAC in either case. So an ultrasound is a good first risk stratification step, and it can give you a lot of information in terms of the appearance and risk of malignancy and the need for further investigations. Yeah.
I think to summarize that, I think we can get a very good clue from the thyroid ultrasound. This is a benign thyroid nodule. If you see, it's a round nodule with a peripheral halos present, and there is absence of microcalcification, which is common in patients with papillary thyroid carcinoma. Compared to this nodule, you see the borders are irregular. There is no peripheral halos there. And then there are certain microcalcifications there, which is suggestive of an papillary thyroid carcinoma. And these are the features of a malignancy in a patient with thyroid nodule, which is usually the malignant nodule will be an hypoechoic lesion, maybe a presence of microcalcifications, absence of halo, internal or central blood flow, taller than wide shape, an extrathyroidal extension. And recently, we come across several things, what we call testerads, as Dr. Usha said. So probably still we are not used to that. We are used to BIRADS, which actually classify the breast cancer or something. But TIRADS is the one which is promoted by the American College of Radiologists to stratify the echogenicity and the cancer potency of the thyroid nodule. So these are the components of TIRADS. The one is, first one will be a composition of the nodule, second one will be the echogenicity, shape, margin, and echogenic foci. Depending upon that, they have given us certain points, and if the patient have TR1 or TIRADS 1, it is benign where no FNAC is necessary. And if the patient have a TIRADS 2 and it is not suspicious, there is no need for an FNA. Previously, we know that for any nodule, we should do an FNA to prove it is not a malignancy. But now we have certain clue that which nodule we can left alone to show that, so that we can follow up those type of patients. And if the patient have more than 7 or more points, it is highly suspicious of malignancy, and we have to do an FNAC. So this is the ultrasound of our patient. Nothing has been mentioned except for the size, and also it shows a multiple cystic foci within, and not much mention about anything about the composition, shape, or margin. But the size is fairly large. It's 3.5 to 2. Yes.
Just a quick comment on that. See, the ultrasound prediction of a benign nodule versus malignant nodule was initially, the TIRADS has been there for a long time. And I think multiple players have used their own scoring systems. There's the Korean TIRADS or the European TIRADS, and now the Americans have understood that TIRADS is an important tool to risk stratify the nodule. The American Thyroid Association initially had a pattern recognition system where they had very low risk, intermediate risk, and high risk. I think the ACR TIRADS now actually has shown to be a much more superior method of stratifying, not just because it has got more point system and it's very methodical, whereas in the pattern recognition you may have a pattern where you really cannot give a scoring. The point to keep in mind, all these scoring systems are geared towards diagnosing papillary thyroid cancer. A follicular adenoma, a follicular thyroid cancer cannot be diagnosed using, or these methods are not good for diagnosing those kind of cancers. So you may have a very nicely benign appearing TIRADS 3 nodule, solid, isoechoic, rounded, nice halo, still turn out to be a minimally invasive follicular thyroid cancer. So these criteria that are given, the taller than wider, the microcalcifications, the infiltrative borders, deeply hypoechoic, no halo, those are all features very classic of papillary thyroid cancer. So these are very good predictors of PTC, but they are not good in terms of diagnosing your follicular neoplasms, either follicular adenomas or follicular cancer. So that's an important point to keep in mind.
Yeah. Next will be, should we do, as the TIRADS classification as say, should we do an FNNC for all thyroid nodule? I think the answer is already given. If the patient have any characteristic which is not given below, we should do an FNAC. One is a lesion with a low suspicious of malignancy. If an FNAC of more than 1.5%, FNAC should be done if the size is more than 1.5 centimeter. And if the spongiform lesions are there, we can observe or do an FNAC if the size is more than 2 centimeter. And if it is a purely cystic lesion, we need only just a clinical follow-up. So this is what the FNAC of our patient has done. It shows that this patient, this patient have a follicular neoplasm with the secondary changes. So now we have a patient, it's a 32-year-old, and FNAC showed a follicular neoplasm. So how to approach these patients? The patient with a follicular neoplasm, nowadays the cytology, what they have proposed is to do a scoring system further once again to risk stratify the thyroid nodule, which is what we call it as Bethesda system for cytology reporting. To enumerate that, can I ask?
Yeah, previously the FNAC was categorized into 4, where basically as benign, indeterminate, or non-diagnostic and malignant. So the indeterminate category, which comprises the majority where it is a cat on the wall. There is a very difficult to differentiate between a benign or malignant. So they further subclassified this indeterminate into further 3 categories. So the standard classification of FNAC has further been subclassified into 6 categories by the Bethesda system of FNAC. So the follicular neoplasm previously, which has been categorized, further divided into 3 categories based on the cell pattern as well as the nuclear features. So the third one will be the follicular cells or follicular lesion, where the probability of malignancy will be around 5 to 10%. And the fourth one will be suspicious of follicular neoplasm or minimal risk in the type of malignancy around 20 to 30%. And the fifth one will be highly suspicious of malignancy, where the possibility is around 70 to 90% based on the nuclear features as well as the cellular arrangement as well as the microfollicular formation. So the Bethesda system is now the standard of care in reporting of FNAC all over the country or majority of the endocrine centers.
Yeah, I think the Bethesda system actually stratify the chance of cancer in a patient with a thyroid nodule. But we have a clear-cut thing that if a patient have an follicular neoplasm or malignancy, we can. But there is an intermediate one which we call it as follicular neoplasm of undetermined significance. So this is where to go for a surgery or not is actually this one. So can I ask Krishna he has I think, article published in this one, how to approach a patient with a follicular neoplasm of undetermined significance.
So the important thing is that you're looking at somebody who has an intermediary chance of malignancy. That's right. So if you look at the traditional 3, 4, and 5, you're having increased risks of malignancy in the Bethesda system. So the first thing is with the Bethesda 3. Given the fact that you don't have molecular markers readily available, the simplest thing is to, what I would recommend is in the Bethesda 3 is to actually do 3 things. 1, have it read by another more experienced cytopathologist. This reclassify, a lot of times cytopathologists with less experience will when they're not happy with the B2, they will just add that B3 just to hedge the bet. So you really want it redone by someone who's more experienced, so a central reading helps, the first part. Second is correlate with the ultrasound. The ultrasound is a great tool. Don't forget the ultrasound just when it's done once. So you look at the ultrasound and there is a discrepancy, then you can think about more things. Third, then you can always re-aspirate. So you can wait and so in my view, and not necessarily supported by a whole bunch of literature. Yes, there is some support. So these 3 things are great for B3, right? If these don't work, I think surgery is very good. Yeah. If you have the option of getting what is it called, the molecular markers, then this gives you an additional benefit. Yeah. Or then do a lobectomy. In a B4, where you are looking at by the way, there is a newer version of the Bethesda, 2017, so please be familiar because a lot of cytopathologists are still using the 2007 classification. We need to use the 2017 one. In the B4, the important thing to remember is there you are going to offer surgery irrespective. The molecular markers there are going to tell you the extent of surgery. It is and there, the molecular markers that you use are not the general one where the negative predictive value is high. You're looking at where the positive predictive value is high. Therefore, what you really want to be doing is a bunch of molecular markers. And I'm going to ask Dr. Subramanian Kannan also to come in because he's now working with a chip that's looking at these markers. And so if these are present, great. And for most of us, these are not present. So you need to make an informed decision with the patient whether you want to do a near total thyroidectomy based on the ultrasound characteristics, or the better thing is to say, have a consent saying, look, I'm going to do a lobectomy, and then in the theater, if I find that the frozen is positive, there are other indicators, we will complete the surgery. This is the second part. In patients who are suspicious for malignancy, which is the B4 where the risk of malignancy is actually exceeding 60%, surgery is the answer. The molecular markers are again there present to help you determine surgery, but you really don't need. Where do molecular markers work? To rule out in B3, to include in B4. In B5, not much of an help. Can you briefly talk about your work? Because this is exciting work. I started work on BRAF and TRAS 5 years ago. Dr. Kannan's extended my work into a chip.
So we've not done anything new. I mean, we have basically looked at the same genetic panel markers that were introduced by Nikiforov in Pittsburgh about 10 years back in his original sequence that he looked at thyroid nodules, particularly the indeterminate nodules, so which include the BRAF, the RAS mutations, two recombinations as well. And when we use these 6 panel mutations in the indeterminate forms, and we found that the positive predictive value is quite high. So if you have somebody who's got an indeterminate nodule and who's got a mutation positive, it's very likely that you're dealing with likely a malignant nodule. So the rule-in or the positive predictive value of these markers do play a role. Again, they are not the gold standard, or that is not the first thing that I would do. As Dr. Krishna mentioned, whenever we get an AUS or an FLUS, the first thing is to go back to the cytopathologist to see why did they call it an AUS. Is it a nuclear atypia? Is it a cellular atypia, architectural atypia? Or is it because of the preparation was not good and that's why it's looking atypical? Maybe the blood cell, the follicular cells were caught in a blood clot, and so that's why they looked a little atypical. So you want to know why they call it atypia. Once it's atypia, then you go ahead with the option of either redoing the FNAC or doing an extra panel of molecular markers. And once that is done, and again, if you go back to the ultrasound, you look at the risk prediction model. If you have a TR4 or a TR5 nodule with a Bethesda 3, that is a nodule that I would probably send for surgery. Whereas if I have a TR2 nodule that I have an AUS or an FLUS, I probably ask the patient to come back in 3 or 6 months and re-aspirate and see about 20 to 25% will restage back to Bethesda 2. So that's important. So you're looking at, so this is important when you do an ultrasound, do the FNA, but then go back to the ultrasound to see which way do you want to go to. If you're TR4 or TR5 nodule, if you have an atypia, go ahead with surgery. Whereas if you have a TR1 or TR2 nodule, then probably wait, re-aspirate.
Yeah. We have 10 more minutes, only 20 minutes showing. So to summarize what they have said, we have, if the patient present with a Bethesda staging of 1 and 2, I think surgery is not necessary. 4 and 5 and 6, I think we should recommend surgery. 3 and 4 is a gray area. Probably we should look into whole as a patient, the size, the clinical presentation, and also the other things, so that to recommend surgery in this group is actually, it should be a group discussion rather than a single one. So when a patient have an FNAC which comes as benign, when should we repeat it? So we shall have it.
So as we've just discussed, in nodules of indeterminate significance, we may want to wait if we don't have, especially where we don't have access to molecular markers, and if clinically the correlation between ultrasound clinical symptoms would suggest that it's safe to wait, then you could easily wait 3 to 6 months and repeat the aspiration and then see how it goes. If you get a non-diagnostic sample, most certainly we should be thinking of repeating. The gray zone is where you get a nodule that is maybe a Bethesda 2 or a Bethesda 3 maybe with an indeterminate significance. Bethesda 2, there is 2 trains of thought. One, that if you have a reasonably good sample and if it is clean and if you're sure that this is going to be benign, then perhaps you don't need to re-aspirate, but most guidelines have until recently recommended actually the 2007 and 2000 the ATA guidelines used to recommend re-aspiration, but we have moved away from that. Where else would we re-aspirate?
Yeah, I think this is what the American Thyroid Association recommendation.
So so the thing is that when you repeat the FNAC for any of these follow-ups is when you follow them up, and there's so two things. You do an ultrasound follow-up, is there a change in the size and change in the texture. One of the things that I insist on is that they actually repeat the volume, that they report the volume and not necessarily just the 2 dimensions. This is something that radiologists do all the time. They will do 2-dimensional reporting. What you really want is a 3-dimensional reporting where you can measure the volume. Usually, a greater than 50% increase in the volume or any change and upgrade in the texture, let's say from a T2 to a T3 or a T3 to a T4, definitely requires re-aspirate.
Yeah. Yeah. So any low suspicious nodule more than 24 months, and if it is intermediate suspicion, 12 to 24 months we have to repeat. So we know that several practitioners do treat the patient with a suppressive thyroid therapy. This is recommended? No question. Should we recommend a suppressive thyroid therapy in
No,
patient with thyroid?
I think there used to be an if and but about this, but I think the answer should be no. The important reason that we are saying this is that even papillary thyroid cancers, the idea is you're following these nodules because you want to see if there's growth. If there's a decrease in size, what is going to happen is you're going to miss the growth in a significant way. And there's no data to support this kind of outcome. I think we should not suppress nodules at all.
Okay. So the patient, our patient have a thyroid nodule of around 3 centimeter with a follicular neoplasm. I send the patient to a surgeon. So how to approach this patient, Dr. Garapati?
Actually, as previously said, there is a clear indication for surgery like Bethesda 4, 5, 6, definitely we'll go ahead with surgery. Surgery in the sense we'll do a neototal or a total thyroidectomy. That means we'll remove all the macroscopic thyroid tissue, whatever is possible. And neototal is just leaving less than 1 gram of thyroid tissue, so that can be taken care by the, if at all a malignancy, that will be taken care by the radioiodine therapy. So another thing, after malignancy or highly suspicious of malignancy, next will be a compressive effect because of any iridostomal extension or big nodules that can compress on the adjacent structures, especially the trachea, then we would offer surgery. Another thing is long-standing toxic multinodular goiter, which have been an antithyroid drugs, which would require surgery after failed antithyroid therapy. Another one will be a cosmosis, that will be the last one which we'll offer, that we'll discuss with the patient. So main thing is for malignancy and suspicion of malignancy will be the first one. Second would be the compressive features. The third one would be toxicity in spite of medical treatment when there is a failure in that. Then would be cosmosis.
So finally, follow up with this patient has come as the report as the cytology report come as a malignancy. I think the important why I put the slide is we should not leave this patient. We should go for a remnant thyroid ablation for this patient, so that there is a complete removal of the thyroid gland happens, and it is also important to follow the patient for long term. Look for any recurrence of the nodule. Okay, so this is what our flow chart from the ESKN has given. So to do one TSH, initial TSH, and then FNAC guided, and stratify according to the TIRADS, and then cytology, and then recommend the patient for surgery. Thank you.
I thank the panelists and the moderator. Thank you very much. So we'll move on.